Hello, everyone, and thank you for joining us for today's Our Best webinar, AR Connect, an innovative approach to meeting the mental health needs of Arkansans, which will be presented by my UAMS colleagues, Tony Boaz and Victoria Spradley. My name is Anna Kate Bogards, and I'll be your webinar moderator for today. Before we get started, I wanted to let you know a little bit about the Our Best program and do some housekeeping announcements. So the Arkansas Building Effective Services for Trauma, or Our Best, is a state-funded program at the UAMS Psychiatric Research Institute. And our aim is to improve mental health services for children and families who have experienced trauma. We work closely with multiple partners to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. We recently kicked off a new program, which some of you may have heard about, called the Arkansas Trauma Resource Initiative for Schools, or TRIS, which provides training, consultation, and other resources to schools to better respond to trauma. Through this program, we've had the opportunity to partner with the AR Connect program, which you'll hear about more here shortly, in order to streamline children and families into mental health services. And that's just been a really wonderful partnership so far. So you'll get to hear more about AR Connect here in a minute. And just to do a few housekeeping announcements, you're welcome to ask questions anytime you'd like. So the way that you can do that is that there's a question box up on your screen to the right. If you want to type in your questions anytime throughout the webinar, then we will get to those questions at the end of the webinar, about 15 or 20 minutes before the end of the hour. And we should have plenty of time to answer any questions that you might have. So feel free to type those in for us. Also, if you're interested in earning a CEU for your attendance today, just make sure that you stick around to the very end of the webinar, and we'll provide you a code and some more instructions on how to get that CEU. We are recording this webinar, and we'll upload that to the Our Best YouTube channel. We've put other previously recorded webinars there too, so you can check those out. And also, lastly, don't forget to check out the Our Best Facebook page and like us. We frequently post upcoming webinars, training opportunities, and other resources there, so don't miss that. So let's get started with our webinar. First of all, I would like to thank all of you who are able to make it in the various weather conditions that a lot of us are facing here in Arkansas. I know it's probably a lot of changes going on for you today, and we just hope that you're safe and warm and appreciate your presence with us here today. And with that, I'd like to turn it over to Tony.
Awesome, thank you. That's a good segue. I want to give a little disclaimer before we get going. I'm at home unplanned, and I have 2 dogs, a cat, a 13-year-old. I hope it's not an issue. I am in the back office, but you never know. So if you hear a little meow, or hopefully not the dogs barking, don't be alarmed. Anyway, I am Tony Boaz. I'm the program manager for AR Connect. I'm also director of STRIVE, which is the UAMS's school-based mental health unit. And we also have Victoria Spradley, who's on the call. She is not feeling very well, so she's going to man the PowerPoint for me, and hopefully we are in sync. We are, AR Connect is a partner with the Arkansas Department of Human Services, and these are our grant numbers that we operate under, which I'll talk a little bit more about the grant once we get going. So objectives that everyone here will learn today is we'll get an overview of AR Connect. We're going to talk about innovative ways we connect patients with care around the state, and we also have some non-traditional ways that AR Connect supports others, and then we'll talk about the future of AR Connect as well. So what is AR Connect? We're the virtual mental health and substance abuse clinic for UAMS. It's funded through a pair of SAMHSA COVID response grants. We got the first one about 20 months ago, and it was initially for 16 months. And then while about 8 months into that one, we got another one for an additional 16 months. And then during this time period, we've had a couple of grant extensions. So we're guaranteed through May of 2023 via the SAMHSA grants. We are a 24/7 accessible, free, virtual, comprehensive behavioral health treatment program. Anyone in the state can call and get our services. It's open to all ages. Some of the good things that we see or that we offer is it's free. The grant allows us to not charge our customers or patients. We don't require a referral nor health insurance as well. If someone presents to us and has health insurance, we will bill the health insurance. The grant wants us to do that, but we will not pass along a copay. And then if someone doesn't have health insurance, we will help them get it. But in general, what we do is we do short-term therapy, medication management, and care coordination. We'll talk a little bit about each of those as we go on. So one of the things I really like about this program is we really break down some barriers that are common. I think everybody on this call that works in behavioral health care can speak to the barriers. One in particular is it's free. So that's a great thing for our people. We get a lot of folks that are in need, and they can just call up and get services without worrying about what it's going to cost them. Also, since it's virtual, there's no cost for transportation, which is nice. Like I mentioned earlier, we don't require insurance. We don't require referral. We find that, sometimes there's stigma associated with mental health care and going to the office, and you don't want to be seen while you're going into this clinic. Well, that's not an issue with this. People use their phone, their device, whatever, and they do it from their home. At least we hope it's from their home. We check them, just kidding. We don't have long waits either. Right now, I think when Victoria was putting this together, when someone calls in to getting the first therapy appointment, it's about 96 business hours. So within 4 days. And then we offer all kinds of different resources. We do a lot of community outreach efforts. We're really trying to, a lot of it's about getting our name out there, but also trying to connect with other groups so that, care is something that's everyone's learning about. I'll put it that way, patients and other providers. This is a little slide Victoria put together a while back, but it's really, I'm calling it the AR Connect experience, but it's really a patient experience, and it's kind of the different steps of how it works with us. So we have a 1-800 number, and we have a local number as well, but anyone that's having an issue, they can call the 1-800 number, and they can call that 24/7. And so the nursing triage group over at the Institute for Digital Health and Innovation takes our calls. And what they're typically doing with this first call is they're just screening for an emergency. So if there is a need for emergent care, they're going to refer to the ED and hopefully not have to call 911. We've had to do that a couple times. But in all other cases, what we're operating on is kind of like an urgent care model. And so these urgent care cases, they get connected or they get scheduled directly to our intake schedule. And these typically are done within 24 hours. So the next step is once they get called, our first contact with the patient is a 30-minute phone call. And we do a needs assessment, just asking if you need resources such as food, shelter, education related, insurance related, any types of things like those. We also do a food insecurity measure, and then we do 5 scaling measures. So we do the DAST, the audit, PTSD-5, PHQ-9, and the GAD-7. With this being a SAMHSA grant, there's a lot of data elements that they're looking to collect, and so we built this into that first call. And then at the conclusion of the intake appointment, Dinesha, our intake person, will schedule the patient with the therapist. At that time too, depending on the resource need, she'll contact a care coordinator. Each patient is assigned a care coordinator and they work with the therapist. And so what they do is if there's a need for food, the care coordinator reaches out then and starts. Same thing with shelter, things like that. These care coordinators also assist with scheduling, or at least finding, longer term mental health therapy in the community for the folks. So what we're doing is bringing them for a short term, stabilizing, and then trying to find them longer term care if they need it. Lots of times we're lucky and we can solve whatever episode is going on, because we will do 4 to 6 sessions. But a lot of times we get some really difficult cases and they require longer term. So that's one of the things our care coordinators do. So once they get scheduled with the therapist, that's when we start our virtual care. The first appointment we schedule for 2 hours. It's a diagnostic assessment. One of the things we really want to do is, because these folks are reaching out, have an urgent need, we want to try to get them a little bit of therapy too in that first session. So that 2-hour window is, getting the biopsychosocial information, but also offering some therapy assistance. And then after that, we will schedule, our weekly sessions. And like I said, we do it 4 to 6 sessions, so 4 to 6 weeks. Occasionally we'll do a few more. There's no real rule that it has to be done in 6, but it's kind of just like the average that we look at. We have a couple different MD psychiatrists that work with us, and so we can do medication management when needed. And obviously that's virtual as well. So there are some limitations on certain kind of meds they cannot, like controlled substances, they cannot prescribe. But your other typical run-of-the-mill, Zolofts and Prozac and those types of things will get people started. Once again, we're trying to help stabilize so that they can move on to longer term care as needed. So I mentioned earlier with SAMHSA, they like us to collect a lot of data. And, I'm a therapist, but I guess I like numbers a little bit. So I thought, it'd be nice to put some data in here. So since we started, Triage has received over 2,500 phone calls on that 1-800 number. And it's resulted in 1,400 patients that we've seen. And it's interesting, I do some clinical supervision for a couple of therapists, and you just, every day is a little bit different, right? So with that said, we have ages ranging 5 to 94 years old so far. So you got to be agile, as I call our group. We also have we've served 200 resource only patients, and what that means is they may come into the intake and Dinesha will go through and ask what kind of needs they have, and they don't necessarily want mental health care, or maybe they have it scheduled with a provider in the community already. But what we'll do is we still do all the resourcing, where our care coordinator will reach out and find them whatever they were needing, whatever they were missing. I'll put it that way. And we call those resource only because, they're still important to us, and everyone, they need the resources, so we want to provide it for them. And one thing we did probably, 6-8 months into this process is we put together what we called an online resource center. And so that was what Victoria, myself, and Brian, who's our lead care coordinator, we were just, looking up all kinds of resources, finding different things, and putting it all in one spot so that anybody who needs resources can find it. So I haven't looked at it in a while, but we have it set up in 5 regions in the state. And so if someone's in Northwest Arkansas, they can look in their area of the state. We also have substance abuse and alcohol related resources on there, and some other information as well. So it's a great resource. If someone's on the resource center, they can't find what they're looking for, they can message us directly, and we can then go and look it up for them too if they need to. on average, we get about 35 intake appointments a week. I would say, let's see, the last 6 months, that's probably what we've been averaging. When we first started this, we didn't get as many as you could imagine because it was a brand new program. So we didn't have a Victoria. Victoria is our outreach coordinator. I don't know that I mentioned that. And so she does a lot of work, you know, pushing the program out to all these different areas of the state. And so we've seen that that's really helped business over the last 6 to 8 months. Mid-December, we had 46 completed intake appointments, and that was our highest we've ever had. So what that meant was 46 new patient scheduled for the therapist. So that was a lot. It kind of tailed off over the holidays, but we're back up. I just did a report today. We had 25 completed intakes, and that's with the holiday, which we weren't open. So we took calls, but I mean, just the clinic-wise, we weren't open. What we found too with this data is, I had mentioned that on the intake, we do a PHQ-9, a GAD-7, and there's other measures. Well, each subsequent session, we do a PHQ-9 and a GAD-7. It's just a common practice we do. And so over time, we have looked at the reporting for each of these from the client's perspective, and both have shown statistically significant improvement. As you know, as we really hope, that's what you want to see as therapists. You want scores to go down, and so that's what we've seen. It's really kind of fun to share that with our therapists so that they can see that they're being effective. And then we also, part of the grant requirement is we had to have an outside evaluation team. And so this is an ongoing process, and we work with the University of Wyoming, and they are always, they interview clients, they interview us. It's just an ongoing, we get I don't know if it's quite quarterly, I know it's twice a year we get different reports back to us, what they've seen. And it's very interesting that we get to see this because we can make changes. We don't have to wait years. We can make changes now that'll certainly affect patient care. So it's a neat thing to have for sure. So one of the things that we have found to be very valuable with expanding this practice is just the partnerships we've made. Being that we are a UAMS program, and you know, UAMS is something like 11,000 employees, something like that. So there's all kinds of different programs going on. And you know, one of the things we did was we're trying to get people to know what we're doing. So one of the first things we did is we started working with this group called regional programs. And so UAMS has these programs around the state. Oh, I should have a list, but I don't. But there's probably 6 to 8 of these. And so this is where people go to get their primary care. And so a lot of times what will happen is there's a behavioral health component there as well. Like they have a therapist that will work with the PCP provider. But it may get out of their comfort zone, or they may have had somebody that's been on meds for a long time and is struggling, and the PCP just really doesn't know where to go. So we do psychiatric consults with them. And then ultimately they end up a lot of times getting therapy with us as well. And so they start to look like what we would say just like your normal AR Connect patient. But one of the neat things is we have a nurse on staff that can then go back and consult with the regional programs team for, you know, the results of what's going on psychiatrically. I don't know. Anyway, another thing we started doing, which has shown to be a great interest, is the UAMS emergency department. They get all kinds of people coming in at different types and different issues, and a lot of people will get admitted directly to the inpatient unit based on, you know, what's going on. Maybe they're suicidal. That's probably the most common thing. But a lot of times they will have some folks that they're not acute enough, let's say, to be going into inpatient, but they may have done a safety plan and then they're discharged with follow-up appointment out in the community. Well, what we started doing is the social workers in the ED will email us and let us know that they had a patient that didn't quite meet that need to go inpatient. So we will follow up within 72 hours and just give them a call, see how they're doing, and offer our services if needed. So we've had some that come in and get our services. We have some that have them already in the community, so they're fine. And we've had lots of people just thank us for calling. So that's been an interesting little partnership for us. Similarly, we do something with Children's Hospital with the pandemic. There's been, a lot of inpatient places have been full, or there's been issues related to COVID. So, accessibility to inpatient care isn't or hasn't been at what we're used to. So they have had some kiddos over at Children's that they may not meet the criteria for the inpatient placement, but it's still a significant need. And so what we've done with them is kind of streamline that process to where they can call, or the ED social workers can call with the families to get an appointment with us before they leave the ED. And we found that that's, help to where people are going to follow up. Now we're still doing the same thing where we're doing longer term care in the community, but the cases that we've seen from that have shown to be successful in, the people will call us if they make the appointment from the ED. So there's that. And this is the one we talked about earlier, the Trauma Recovery Initiative for Schools. Nikki and I kind of brainstormed this together when she was writing the Blue and You grant. We were also writing a Blue and You grant at that point as well, and thought it just made perfect sense that if RBEST is out in the community talking about services available to kids and or trauma related, things out with teachers, that if there was a need that popped up with a kid that needed services that couldn't get them, then we would streamline them into our program. And so when we do that, what we're doing is really just trying to provide support as quickly as possible, whether it's for the family and the kiddo. So with the family, we will do some care coordination, see what kind of needs they have. And obviously, if they want treatment, they can get that as well. But what we found is this has been a really good partnership. The therapists and then our care coordinators work with the RBEST navigator to try to find, permanent trauma-focused care in the kids' community. We've had a couple cases where we've seen them for several sessions, and long run, I would like to provide the solution and be the long-term if, say, the community didn't have available resources. So that's something Nikki and I continue to talk back and forth about. That's been a great partnership so far. The newest one that we're working on is the College of Nursing. UAMS College of Nursing has reached out to us. Obviously throughout the state, being that we're a rural state, there's a lot of just needs out there. Well, one area they're working in is Southeast Arkansas. And so they are doing some grants to where they have volunteers will go out and do screenings for suicidal ideation, depression, those types of things. And they didn't really have, a referral source, like what do we do when this happens? Because there's just not a whole lot of providers down there. So what we're going to be doing is working with them to where they have our information and we get them, a streamlined process for for that population. Right before we were putting this together, we have more partnerships too. But these are the top, I'd say 5 that we work with the most. So care coordination, we've talked about this. This has been something, kind of goes along the lines of the old school case management. It's not a billable thing for us, but because we operate off a grant, it's been great that we can offer services that aren't reimbursement based. And so the main one that we're really doing is care coordination. And so I mentioned earlier, this is where we are doing what I call resourcing: food, shelter, health insurance, education, referrals for long-term care. This is where we have people reaching out to the clients, checking in on them, making sure, hey, let's get you, okay, here's a list of 5 food banks, right? And here's a list of 5 providers in your area. And we know that this provider is taking, referrals actively. And we'll talk about that later. But also care coordinators do some other things as well. They do follow-up calls for ED, like I mentioned before. And part of our obligation to the grant is when we do those 5 initial scales and intake, we're supposed to do a follow-up at a month and then a follow-up at 6 months. And so what we do is we have our care coordinators do these follow-up calls. And a lot of what we do right now is in Epic, we can send messages to the patients if they're a MyChart user, and we can attach the measures so that people can just fill them out. And that's been working really well. And then we also, with the population that we serve, we get a lot of cancellations and no-shows. I think I had mentioned we did 25 intakes this week. Well, we probably had 35 scheduled. So we probably, so we lose 10 that don't show up for their intake. And then we schedule 25 therapy appointments. We may have, 12 to 15 people that are successfully attend the appointment. So we do have a lot of reasons to follow up. And so they assist with our access staff with trying to reschedule cancellations and no-shows. So they stay pretty busy. So another thing that we have really focused on is community outreach. I wish Victoria would come on and talk about this because this is her thing. This is her jam. But I'm just kidding, Victoria. Anyway, one of the things we were able to do once we got the second grant was really focus on expanding the program. The initial grant, when we got it, we had 4 therapists, 2 care coordinators, and a couple of other staff. We're up to 19 now. And so one of the positions we have is an outreach coordinator. So Victoria's full-time job is doing presentations, going to conventions, making partnerships with police departments. We've had a lot of outreach with Little Rock Police and North Little Rock Police. She does presentations for EMS providers. We did a big thing with the unsheltered population a little while back. I think that was in October. Regular talks at libraries, churches, you name it. She's done, I want to say an AARP thing is coming up. We also have several presentations coming up as well. One of the things that's interesting about this program, because it's new and because it's grant-based, we offer just support wherever we need to. And what I mean by that is when we had some displaced folks from the last hurricane that came through, we had a gentleman that had ran out of his medications and he didn't grab a script because he was, needing to leave real fast. Well, we were able to see him. He called us. We were able to see him. He got into the psychiatrist within, gosh, I want to say 24 hours. We did a quick diagnostic and he had his medication refilled. I know it was about 24 hours, so that was really cool. Cool way to help. And then when the last tornado came out, or the round of tornadoes came through Northeast, we were able to, I just emailed the town and said, hey, or the mayor, and said, what kind of services you guys need, assistance, here's this phone number. It's as simple as making this call. So we were able to help some people with there as well. So it's been really interesting. One of the latest things that we have done, and there's a lot of folks on here, and I'm just guessing, I'm hoping all throughout the different parts of the state. One thing that we're not interested in is taking anybody's business. What we want to do is make sure people get long-term care if they need it. We will stabilize, and we want to get them back to community partners, mental health partners. And so one of the things we did recently was send out a survey monkey, and we were just basically asking, hey, are you taking referrals? How long's your wait? What's your specializations? Those types of things, just so that we have some sort of database and we can get people in. You know, there's some clinics out there that have a 6-month waiting list. You know, and so if we can find other options, as long as the provider, I mean, not the provider, but the patient is good for other options, then we try to do that. We also can spread out our care a little bit. I said earlier that we did weekly sessions. Well, depending on maybe there's a wait of 2 months or something at the next facility, we can do every other week sessions as well, so that there's not a huge gap in between our care and then the next longer term care. So we're still getting those back. I think the last count, we had 40 different provider groups email us or at least respond to our referral request. And then I think I just touched base on this. I'm really bad about going ahead and talking, but over different bullets. But you know, what we're really looking at is establishing or reestablishing long-term care. We have a lot of people that have had care for many years, and for whatever reason they had to move, or they had to, you know, something happened with COVID and they no longer are with that provider. And a lot of times they don't know how to get back with their providers. So that's the assistance that we can provide them. And you know, what we want is everyone in Arkansas to have better mental health care and to just feel better about themselves. So we feel like we are helping out that cause for sure. Cool thing that we started doing, you know, I don't know how innovative it is, but one of the things that we have available to us is we have a lot of therapy time. And I want to make sure that we can provide assistance as we can. And I mentioned earlier that we do a lot of things that aren't typically reimbursable. So one of the things we started offering, gosh, I think it was in fall, is a weekly medical professional support group that people could just call in, and we'd have a group of folks. It's not treatment. We partnered with the EAP and just kind of said, hey, this is a support group. Call in. You can be anonymous if you want. And, you know, we have 2 therapists that'll be on there, and we're just talking as a group. Let's make things better. And we had a lot of participants that would call in, and it seemed to be working fairly well. We even expanded it to where we had another time. Now, surprisingly, I haven't had as many people use this as I thought, but I think, you know, this isn't just for UAMS. It's open to any provider that would call in. I just think there's some hesitancy, you know, for UAMS folks, because they think it might be treatment, but it's not. We don't even keep records. But then recently, within the last month, we started a school employee support group. We just did our second group this week, so it's still relatively new, but we just sent it out to, you know, with being at Strive, I have connections there with North Little Rock School District, Little Rock School District, Police Academy, and then I know through various outreach things, Victoria had some contacts as well. So we were just kind of pushing it out there to see what the response would look like. In our groups, we limit. Oh, here's the kitty. I thought I'd get through the presentation without my cat. Anyway, so we keep the group small. We do 10 at a time, just so, you know, we can have some sort of control of the group. And we had 10 people sign up within 3 days. So we feel like there's going to be a need to offer more of these groups. So once we get a couple under our belt, I'm guessing we're going to be offering more. So, but oh, you're fine. We're also sending out an eval. We're going to start so that we can see if there's anything, you know, maybe we're not doing, or maybe there's a different time, so we can adjust it to the needs of our folks. Go ahead, Victoria. I'm sorry. Future of AR Connect. I mentioned earlier that our grant sunsets in May of 2023. That's when our current, the second grant is no longer. You know, one of the things we're trying to do right now is build this model that's sustainable, and we want to keep all of these other things that aren't your typical reimbursements with the model. So there's some challenge there. There's some other challenges with you know, taking people that don't have insurance, not collecting a copay. So there are things there, but we're working towards it, and we're fairly confident we're going to be able to continue this program. We're seeing people in different parts of the state that would no longer, they just wouldn't get any care any other way. And so that's what we want to continue. We may have to make some adjustments. Maybe we become a long-term solution, but we'll wait and see. But we know we'll have to make some adjustments too, like utilization management. We'll need to, like right now, if we have a Medicaid client that comes in, we don't get a referral, just because, you know, it's just the nature of the thing. So we know if we were to do this longer term, we would get a referral and do that type of thing. That's just one example. But, you know, there's been a lot of interest with this program. It's been really neat to see it starting from scratch to where it is right now. I never thought I would have to try to build a virtual clinic, but it's been a good experience for sure. And, you know, I think all of our employees look forward to knowing that it's going to be a long-term thing. So if you need to learn more information, there's Victoria's information and myself. And then if you wanted to look at the resource center, that's how you would get there. And there's also an email. I think we have some information on the support groups. We already did that, didn't we? I'm sorry. One of the things Victoria does an awesome job at is maintains a Facebook and Instagram page and presence for us. She does some really cool posts. I'm kind of old, so the only reason I have Instagram is to follow us, and I don't really know how to do it. And she had to learn how to do Facebook again because you know, I'm old and that's what I follow. So anyway, look us up, friend us, or whatever the appropriate terminology is. There's some more of our contact information, and we try to post things, you know, on a regular basis. Oh, you're fine. So I think I got through that. 37 minutes, yes. So are there any questions?
Wonderful. Thank you, Tony. This is just such a cool program. Very impressive what you guys have been able to build just over this short time period. We did have some questions come in. One person wanted to know if clients are required to be residents of Arkansas.
No, they don't. They have to be in Arkansas at the time of services. So one of the regional health programs is in Texarkana. There's one in Fort Smith. So we've had some people from Oklahoma that would get our services while they're in the office at the clinic.
Okay. And another question came through. They were wondering, so would this be more people who are kind of in an acute or crisis situation, or would this also be for someone who's just looking for therapy that doesn't have any other emergent needs besides just wanting to be connected to a provider?
We take all comers. So
okay.
It's some, you know, it can be the urgent care. It could be somebody that has always needed or always wanted a therapist, but just, you know, for whatever, and they just have never called. And so this is a way for them to connect and get it going.
And if somebody listening would like to be on your referral list, how would they do that with you?
They could contact Victoria. That would be the best way. And then she could send out the link and they could fill it out. And then we would go from there. We're keeping a database just because it's beneficial, you know, for everybody involved, that we're getting the care for the clients, the patients, and in their community. So that's just great information for us to have. So we'll be more than happy to send that out.
Right. For everyone who's listening, after the webinar, I'll send out an email with information about the CEUs, but also I'll make sure you have all of that contact information for AR Connect, and so you can follow up with them if you would like to do that.
Yeah, and just real quick, if I throw this out there, is you'll see it at the bottom of each slide, there's just a general information email, you know, arconnect@uams.edu. It comes to me. And so if you have any questions, they can go there as well. We get clients that call, that email saying, hey, can I get some services? I had one that sent me an email last night. I sent her the 1-800 number. She's on the intake for today. So it happens fast.
There were a few questions about the resource center. So this is, just to clarify, this is online resource center. So these aren't actually physical locations where people would go and get resources. This is just off your website.
Yes, and I maybe not have clarified that, but it is. It's an online resource.
Okay. Let's see, what else did we get? Someone was asking for flyers. So yes, I will send out flyers for you to share. Let's see, what else came through here? Sorry, I'm just scrolling through some of these questions.
No, that's fine.
Someone was wondering, they work with a lot of families in the foster care system that can be, you know, pretty traumatic just to get them into services. And so they were wondering if AR Connect would be a good first step to help them stabilize while they're, you know, waiting to get into their long-term care.
Yeah, I mean, it could certainly be something we could do.
Okay.
I don't know that I've ever said no. Victoria, have I ever said no to anybody wanting to come in? I don't think so. You know, obviously we have some limitations. Obviously, you know, when you're talking about virtual care, there's always challenges associated with, you know, making sure they have a camera that's appropriate, making sure they have a device that's, you know, those types of things. But that's really it.
Let's see, that's mostly the questions we have. I was going to mention, you know, how this has been so wonderful for Tris and Arbus to work with AR Connect is that we are often asked to help kiddos get connected to therapists who are trained in evidence-based treatments for trauma. And so we've had kind of a limited care coordination role that we've been doing for a long time, but it hadn't been very centralized. And when we were expanding to working with schools, we really wanted a way to just a central place where we could tell any teacher in the whole state, if you have a kiddo who needs services, you know, this is what you do. And so working through AR Connect to do that has been just a really wonderful way for us to bring children who are out in schools who are identified as, you know, might be having a need for trauma services. Then they work with we have a care coordinator working just on Tris who works with the AR Connect team. And so that's been a way to connect kids to services who otherwise might not have been able to immediately find it in their own communities, or maybe their teachers or staff at their school weren't aware of how to help them in that way. And so for any of you listening, you know, I'll definitely be sharing that information by email on how to spread the word about AR Connect, because it's a wonderful way to connect people who are otherwise, you know, isolated from services that they need. So.
Well, I think we're going to continue that partnership and hopefully see it grow as well with y'all's group.
Well, let's see. Looks like that's all the questions we have. Since you have all, see, I think I have control too. Let's see. Oh wait, one more came in.
Yeah.
Someone was asking about Tris, about if it would be a good topic to present to attorney ad litems. Yes, Nicole, I will, whenever I send out the email today for the webinar participants, I'll make sure to include some information to follow up about Tris, and you can talk to me, but you can just respond to that email from me. We'll follow up on that. So. All right. Let me advance to the next slide here. For those of you all who are wanting to get CEU credit for this webinar. I will be sending a link to a survey, and it's a Google form, and you fill that out and you enter this code here, 2402. Once you enter it and submit that survey, you should receive an automated email back to you with your CEU certificate. That email will come from the RBES info Gmail account, and it will be from Chad Sievers. Sometimes people miss it and it goes to junk mail, so just keep a lookout for that, and feel free to email me if you don't get the email for some reason or get your certificate. And with that, I think we're good to go. Thank you, Tony and Victoria. This has been a wonderful presentation. We're really excited about your program and hope to continue to work together and spread the good word about what you do. And thank you to all of the participants who came today, and I hope you have a wonderful rest of your day.
All right, thanks for having us.
Mm-hmm.